The purpose of the presentation is, as you can see on the title, is how to read the ventilator integrated polygraphy in a patient under non-invasive ventilation. So, as you know, and as you can see on this picture from a publication of Jean-Paul Janssen in Respiration, the pathophysiologic rationale for long-term non-invasive ventilation is ventilatory pump impairment related to different causes, of course, causes from about neuromuscular disease, maybe related to respiratory control, related to motor neuron disorders or muscular disorders, and also diaphragm maybe work in difficult condition. It's the case for when thoracic compliance is decreased or pulmonary compliance is decreased, and also we have a lot of patients with respiratory failure which are related to increased respiratory airway and of course COPD. Here is on this slide the major indications of long-term non-invasive ventilation. Of course, obstructive lung disorders, obesity, hyperventilation syndrome, restrictive disease, neuromuscular disorders, and indeed less frequently NIV for the treatment of sleep-related breathing disorders, obstructive sleep apnea and central sleep apnea. So in my experience, it's very, very, very few indications of non-invasive ventilation in this indication. Respiratory polygraphy, you can see on this published in Thorax by Sono NIV group, which I belong. Respiratory polygraphy is the last exam to be performed for monitoring non-invasive ventilation. So far, different steps have to be checked or have to be checked previously. Of course, what I'm calling the basic pack, which includes clinical state, arterial blood gases, what do we know about oximetry, nocturnal oximetry, what do we know about compliance of the patients about non-invasive ventilation, transcutaneous capnography, of course, and also data from the ventilator software. And we had last years these lot of progress by a different company, and ventilator software, very interesting because on this software we can know what about leaks, apnea, hypopnea index, median tidal volume, and with all those tools, a lot of settings can be adapted. So far, although polygraphy and the NIV is considered the gold standard for monitoring non-invasive ventilation, with at least, of course, mask pressure monitoring, flow, thorax and abdominal movements, oximetry, and transcutaneous CO2 if available, or if oxygen is adjuncted on the ventilator, using a pneumotachograph needed an admission at the hospital. Recently, Breas company developed 2 ventilators able to perform respiratory polygraphy, and this is very, very interesting. On these ventilators, it is possible to connect oximetry, thorax and abdominal belts, and transcutaneous CO2. As a result, of course, these signals added to pressure and flow signals monitored by the software build a real respiratory polygraphy. Integrated, so it is a real integrated ventilatory polygraphy This integrated ventilatory polygraphy record mask pressure, of course, patient flow, total leaks, SpO2, and thorax and abdominal belts. Thoracic belt is in pink color and the abdominal belt in black color. Regarding to the latency of transcutaneous CO2 signal, recording this signal on the same epoch, in my opinion, is not of interest. Green color at the top of the epoch indicate a patient triggering. Monitoring total and patient flow is very useful. It is important to keep in mind that patient flow corresponds to total flow minus total leaks, and I will show you later the interest of that. Analysis of ventilatory polygraphy under non-invasive ventilation is complex, of course, because many mechanisms interact. Sleep physiology, NIV adverse effects, and patient-ventilator asynchrony. Indeed, ventilatory polygraphy is the sum of all those phenomena which are translated into different events, such as an obstruction, non-intentional leaks, and patient-ventilator asynchrony. Reading the polygraphy needs different steps. What do we have to look at? And I would say, of course, a ventilatory impairment, a lack of ventilation leading to oxygen desaturation. So as a result, we look at a respiratory event, which definition corresponds to a decrease in respiratory movements or pause in breathing leading to gas exchange disturbance, and in particular, of course, oxygen desaturation. As I told you, reading polygraphy under non-invasive ventilation needs to respect 3 major steps. And it is always the same procedure, but we have it, and this is very, very, very important. Do not do different. You have to respect those 3 steps. And the first one is identify an oxygen desaturation. Second, look for the respiratory event, which precedes, of course, the desaturation on the thoracic and abdominal belts. Third, analyze pressure and flow signals variation for respiratory event diagnosis. As you know, lower respiratory system is characterized by physical properties such as lung compliance and pulmonary resistance. In the case of non-invasive ventilation with pressure-pressed ventilator, pressure, which is constant, inflates the lungs, but the amount of gas inflated or volume depends on the interaction between pressure and physical features of the lungs. As a result, in the case of non-intentional leaks, flow increases, and if the leakage is major, pressure may decrease. So this is very important, and I will show you later a few examples. In the case of obstruction, flow decreases. So it's very important to keep in mind these these technical things related to the functionality of the ventilators to read the polygraphy. Here is an example, and as I told you, first step, so look at the desaturation, look for the respiratory event, and you can see that the respiratory movements are very low. And third, analyze flow variation. In this case, the flow is increasing, then the diagnosis is related to leaks. What can we say about all the features about non-international leaks? In this case again, so identify the oxygen desaturation. Second, recognize the respiratory event on the thoracic and abdominal belts. Third, look at flow variation. Total flow is increasing, then the event corresponds to non-intentional leaks, so this is not very difficult. Now, if you look at patient flow, as you can see, this signal is decreasing. Then, regarding to this signal only, you could make a wrong diagnosis, such as obstruction. Indeed, it is important to keep in mind that patient flow corresponds to total flow minus total leakage. Finally, looking at total flow to make the good diagnosis is, of course, much better. Here is another case. So again, identify the oxygen desaturation, recognize the respiratory event on the belts, to look at flow variation. The result is flow is increasing, then the event corresponds to non-intentional leaks, but furthermore, pressure is decreasing. This later signal is very important because it is pathognomonic or specific of major leakage. And when you have this feature on the pressure, decreasing pressure on non-invasive ventilation with a pressure per set ventilator, you can be sure that you have major leaks. In another case, as usual, identify oxygen desaturation, recognize the respiratory event on the belts, look at flow variation. So I repeat because it's very important. Here the patient flow is decreasing. Is it respiratory? Is this respiratory event an obstruction or leaks? That's the question. If I look at the pressure signal, pressure is decreasing. As a result, the diagnosis corresponds to major non-intentional leaks. So, as you can see, the patient flow could be make a misleading diagnosis, but when you have a decreasing level on the pressure, so you can be sure that you have some leaks on this event. And on this slide, which is the same epoch, as you can see, the total flow makes your diagnosis easier. Obstructions under home non-invasive ventilation are mainly related to upper airway narrowing during sleep. Two great mechanisms may occur. The first one corresponds to upper airway instability. As you know, backward movement of the tongue, impact of the facial mask on the lower maxilla or upper airway collapsibility may be responsible. In this case, identify again the oxygen desaturation. So you can then recognize the respiratory event on the belts, look at flow variation. Here, the patient flow is decreasing. Of course, pressure is constant, so you do not have any major leaks, you can say that. In patients ventilated with pressure per set ventilator, if flow is decreasing, the respiratory event is related to obstruction. Diagnosing the mechanism now of the obstruction needs to look at two respiratory movements and look at the belts. As you can see in the first part of the event, the belts are out of phase, and in the last part, they indicate paradoxical movements. These abdominal thoracic features I mentioned, out of phase or paradoxical movements, are the proof of respiratory fighting, are the proof of effort, of patient effort, making here the diagnosis of upper airway obstruction without blunting of the central respiratory drive. So we can go further. We can go further learning the respiratory muscle fighting during upper airway obstruction without blunting of the central drive. For that, we have to go back to physiology. As you can see on this slide, during normal breathing, diaphragmatic contraction increases simultaneously the thoracic and abdominal diameters. The polygraphic translation of this mechanism shows synchronism between thoracic and abdominal movements. In other words, and as you can see on the picture, thorax and abdomen grow in the same time with positive deflection on both belts. Consider now a total upper airway obstruction. In the case of an efficient diaphragm, diaphragmatic fighting pushes downward the abdomen and produce an interior aspiration of the thorax. As a result, the deflection of the thoracic belt is negative and the deflection of the abdominal belt is positive. Consider again upper airway obstruction, but in the case of diaphragm weakness, respiratory muscle fighting comes from accessory respiratory muscles, and in particular neck muscles. Then strong contraction of these muscles pulls thorax upward, increasing thoracic diameter and producing an interior aspiration of the abdomen. As a result, thoracic diameter increases and abdominal diameter decreases. As a consequence, on polygraphy, the thoracic belt deflection is positive and the abdominal belt deflection is negative. So as you can see, this is very important to understand that. So for example, in this case of upper airway obstruction without blunting of the central drive, thoracic belt deflection is positive, as you can see. Thoracic belt is in pink color, and abdominal belt deflection is negative. Thus, the patient fights with his accessory respiratory muscles, neck muscles, and this is the conclusion of this interpretation. The great second mechanism of upper airway obstruction comes from central respiratory drive causes. In the case of central respiratory drive blunting, pharyngeal dilators muscles tonicity may decrease. This phenomenon may be emphasized during REM sleep and hyperventilation during other non-invasive ventilation. What happens in this type of situation? So on this example, always the same steps, always the same mechanism of lecture and interpretation. So identify oxygen saturation, go to the respiratory event. As you can see, we do not have any respiratory movements. And in the same time, as you can see, the flow is decreasing. So, of course, again, the pressure is constant, so it's important. You do not have any major leaks. In patient ventilated with pressed ventilator, his flow is decreasing. The respiratory event is related to upper narrowing. If you look at thoracic and abdominal belts, they do not move because central respiratory drive is totally blunted. Here is total upper airway obstruction with central drive blunting. On this picture, you can see an upper airway obstruction. If you look at the flow is decreasing, of course, and you may, on the belts, you can see that there is a period of time with the decreasing of respiratory movements. So this is upper airway obstruction with persisting synchronous thoracoabdominal movements. So here is an example of partial upper airway obstruction with central respiratory drive blunting. We can say partial upper airway obstruction because thoracoabdominal movements remain. So what would you say about this type with this example? So respect the 3 steps again. Identify the oxygen desaturation, recognize the respiratory event, look at flow variation. Here the flow is decreasing again. This is a not upper airway obstruction. And if you look at thoracic and abdominal belts, they do not move at all because central respiratory drive is totally blunted. So what is very important with this integrated polygraphy from Breas is that that we can also have an idea about patient ventilators asynchrony. So if we come back to the definition of patient ventilator synchronism, so good patient ventilator synchrony on triggering is obtained when thoracic and abdominal expansion occur at the same time as the ventilator cycle. And good patient ventilator synchrony is obtained when thoracic and abdominal expansion decreases at the same time as ventilator cycling. So on this slide, I've presented a few examples, and Dr. Arnal will explain to you in detail this patient ventilator synchrony. So I've just mentioned them, and I'm going to show you a few examples. So regarding to patient ventilator asynchrony related to triggering, we know delayed triggering, we know ineffective efforts, and we know auto-triggering. And regarding to patient ventilator asynchrony related to cycling, so we know early cycling, double triggering, and late cycling. So I'm going to give you a few examples. So here is an example of ineffective effort, and as you can see, the quality of the traces is very, very good, and good as well. Then, and I do not make a real difference in terms of quality comparing integrated polygraphy with Vivo from Breas and conventional polygraphy. And as you can see here, we have some ineffective effort, which is characterized by patient effort. As you can see, we see that on the respiratory, on the belts. And you can see also positive deflection on the flow, and this patient effort is not detected by the ventilator. So this is an example of ineffective effort, which is very, very important and very frequent asynchrony. Auto-triggering, so is finally a spontaneous ventilator cycle without any patient demand. So it may be related to a technical problem. It may be related to leaks, of course, too. and sometimes we have to change the machine. Early cycling, it is a ventilator cycle. So in this type of asynchrony, ventilator cycle is shorter compared to patient desire, and you can see that. Double triggering is the case of that one patient respiratory effort triggers two ventilator cycles, and sometimes the clinical meaning of that is that the patient is not enough ventilated, and the correction is to increase, of course, pressure support. Late cycling, in this late cycling, ventilator cycling is longer than patient demand. And you have that. And also, again, Jean-Michel Arnal will explain to you this in detail. So that's what I wanted to share with you. And thank you very much indeed for your attention. And you have any questions? So I'm going to try to answer, because I'm really sorry because my English is quite poor. Thank you very much.
Thank you very much, Dr. Breas, for a very interesting talk. I think one of the big messages, yes, it's important to follow the steps. 1, 2, 3, look for the dead saturation, the event, and analyze, and don't get trapped in thinking that you can change it. There are a couple of questions. On the asynchronies, there are some. How much asynchrony can be tolerated? Is there a cutoff in percentage of breaths?
What has been published in the literature, published by Annalisa Carlucci and other authors, also in Geneva, they studied that. So we know that up to 10% of asynchrony, so you have the patient detect this asynchrony during ventilation overnight, and you may have some clinical symptoms when you have more than 10% of asynchrony during non-invasive ventilation. Do you understand?
Yes, yes. The sound has dropped for a minute, but it's back again, I think.
Ah, okay.
Yeah,
because
so you said,
I hear you very
10%.
good. 10%.
Another question around the patient ventilator synchronization or asynchrony, as you want. Somebody's asking if when a patient is on backup breaths for a longer period of time or even the full night, for you, is that in synchrony with the ventilator or in asynchrony with the ventilator?
When they are under backup rate?
Yes.
Yes, but also for me it is not a lot. It's not a problem. Patients we are treated are chronic respiratory failure, a patient with very weak respiratory muscles. So this patient need to be aided with need to be helped with their ventilator, and these patients, for ventilated, these patients needs to set a backup rate, and if the patient is under backup rate, in my opinion, there is no problem about that. If, of course, the clinical result is good and the arterial blood gases and gas exchange are good and sleep is good.
Okay, thank you. Then we have a question around leakage. Somebody's asking, how do you recognize mouth leak in a patient using a nasal mask?
Yes, so when you look at the flow, when you look at the flow, you have two parts. You have the inspiratory part, which is the first part of the trace, and you have the expiratory part. When you have, when the patient opens the mouth, then the expiratory part disappears. That's a meaning. And this situation when you have leaks related to a mouth opened, it's quite frequent with the nasal mask ventilation. But I do not say that nasal mask ventilation is not good, because it's the better way the better interface, in my opinion. And we have to. It's important to say that, because facial masks make a lot of have a lot of consequence on the maxilla. And in my opinion, the best way for non-invasive ventilation at home is to ventilate patients with nasal mask.
Okay, thank you very much. Another question which came in. If you have late cycling asynchrony, what setting will you change on the ventilator?
Late cycling, so it is related to inspiratory time, which is too long, and you have to diminish the inspiratory time, of course. Okay.
Another one more in general. Will all upper airway events create a desaturation?
Will all what?
All upper airway events create a desaturation?
Not all. Not all.
Okay, because there is a second part on the question is, if it's not, do we only need to correct the events that are followed by a desaturation, is the second part of the question.
Yes, I understand that. So it depends if you are an expert or if you just start reading polygraphy. When you start your formation and you start reading polygraphy and you're not an expert, so you will not see everything, and you will have a focus on the main events, and the main events are events which are followed by oxygen desaturation. And to answer to your question, of course, all upper airway obstruction do not produce oxygen desaturation, but when you are an expert and you are you used to use polygraphy, and you are it's not a problem for you for reading that, so you will try to give a correction of every upper airway obstruction. Thank you.
There is a question which came in, I think, following on your statement about the nasal mask. The question is how much pressure can be used to tolerate to be effective. The person asking the question writes, I found patients who require high pressure have difficulties with the nasal mask and leaks. Asking if you have the same problem with nasal masks and high pressure and leaks being introduced.
My experience, I have 30 years now experience in non-invasive ventilation, and I ventilate patients mainly with nasal mask. And indeed, it is important to give to the patient the good IPAP. And as Mark Elliott wrote in the past, so we have to set that at the good setting. So what I'm saying is that you sometimes for ventilation you need IPAP set at about 22, for example, 22. I think that when you are in between 18 and 22 centimeters of water for IPAP, you may need that, and in my experience, I do not have any intolerance for those settings. I do not need. Usually, I do not need very high pressure for to ventilate my patients, not upper than 25 centimeters of water.
Great, thank you. We have a very active person here on the chat who asks more than one question, and there is a question around the classification of upper airway obstructions. The question is, why do you prefer to classify upper airway obstructions as with or without blunted central drive instead of calling them central and obstructive apneas?
Obstruction with from a central mechanism or so it's this classification upper airway with or without a central respiratory drive blunting was proposed by the Somno NIV group. So we could talk also about upper airway with effort or without effort, which could mean the same thing finally, related to upper airway instability or to central mechanism. So it depends. So we have published in thorax this classification, but this can be discussed by everyone.
Yeah, sure. There's two more questions, if you have the time. One is around, well, the actual application of the Breas system. Have you introduced using the Breas Vivo ventilator with integrated polygraphy? And is that replacing traditional polygraphy, or is it in addition to traditional polygraphy in your clinical practice?
No, indeed, the quality of integrated polygraphy proposed by Vivo 45 and Vivo 45 LS may avoid hospitalization. And I have transformed my care by sometimes my patients came to the hospital to be monitored by polygraphy, and now indeed I use these integrated polygraphy and avoid hospitalization to my patients, and I see my patients with the results in consultation.
Thank you. That's a very interesting conclusion. There is one a bit different question, but and it's the last question of this session. So the question is about all the examples which you show are in pressure ventilation. And do you think there is a place for volume ventilation in NIV?
For volume ventilation, so it's an old question.
Well, it's an old topic, but it's a new question. Yes.
Yes. So I would say that nowadays the quality of pressure-pressed ventilators is excellent, and I do not need really in practical medicine today. I do not need any more volume ventilators.
Okay, that's clear. There's no further questions here on the chat, so that being said, I'd like to thank you again, Professor Perrin, for this excellent talk around the ventilator integrated polygraphy. For all you on the call here today, thank you very much for joining.